Hey guys.
Alicia, Whitney, Steve.
Alicia, Whitney, and Steve. Okay, so any suggestions for what we need to talk about today, guys? All right.
Dr. Ibrahim.
Hey, hey, Steve.
Hey, now Nick and I were talking earlier. We had mentioned about a few subjects to cover. One of them was possibly going over all the types of ablations that you can do, and just briefly kind of explain each one in, no great detail, but that way everyone's aware of the different types of ablations.
Okay, yeah, we can talk about that. So, types of ablations dependent upon what kind of heart arrhythmia you're having. Uh, if you divide the heart to four chambers, two on the top, two on the bottom. The two top chambers on the top, they're responsible for certain heart arrhythmias, and you have certain arrhythmias kind of dependent on both, and certain arrhythmias dependent on the bottom chambers, which is the atriums, which is the ventricles. So the ones are dependent on the atria are the atrial tachycardia, atrial flutter, uh, avienodular intermittent tachycardia, and atrial fibrillation. So we kind of divide arrhythmias into SVTs and supraventricular tachycardias, atrial fibrillation, flutter, and ventricular tachycardias. But the supraventricular tachycardias is kind of broad term, and if I like to divide it into atrial arrhythmias, where you have the atrial tachycardia, either focal atrial tachycardia or some kind of, what we call reentrant tachycardia coming from the atrium. And there are the atrial fibrillation, atrial flutter. So the atrial fibrillation, it's coming from pulmonary veins most of the time. It's very complex arrhythmia. You have to do either radiofrequency ablation, where you isolate the veins and you do other lines in certain areas of the heart in the atrium. Um, and success rate dependent is upon or dependent upon the chronicity of atrial fibrillation. The longer you've been in atrial fibrillation, the more difficult to treat. We can do cryoablation. Granted, the cryoablation, which is balloon ablation, you go and inflate balloon in each pulmonary vein and lower the temperature to minus 70 degrees Fahrenheit, and that will isolate the vein, but that can be done only for paroxysmal atrial fibrillation. So if you're persistent, you can do it. It's not FDA approved. The other arrhythmia, which is atrial flutter, it depends about where it's coming from, but the most typical one, which is the one right-sided flutter, it's very easy to ablate, and you can do it by radiofrequency ablation. The atrial tachycardias, it's focal atrial tachycardia most of the time, and it's coming from certain areas in the atrium, similar to the sinus node, but it's just focus firing at faster rate. These arrhythmias usually is terminated with or are terminated with adenosine, and ablation can be successful in about 18 to 90% of the cases. And the ablation in that case should be RF radiofrequency. So the cryoballoon ablation is only for paroxysmal atrial fibrillation, for pulmonary veins to be isolated. But the rest of the ablations are radiofrequency, which can be done with either 4 millimeter or 8 millimeter catheters, and that is dependent upon what kind of heart arrhythmia you're having. The supraventricular tachycardia is where you can divide it into, again, atrial tachycardia or AV nodal intermittent tachycardia, where you have two pathways around the AV node, and that's also considered atrial arrhythmia, or the one where you have accessory pathway, and in that case you have to have circuit dependent upon the ventricle and the atrium. And these accessory pathways can be ablated with either radiofrequency or focal cryoablation. Usually frequency ablation with catheter is much more successful, but we usually use focal ablation when the accessory pathway is close to the AV node. In that case, it's much safer to do focal ablation. Why? Because you can freeze the temperature, the tissue to minus 30 degrees and see if the AV node is affected. If the AV node is not affected, you can freeze to minus 70 degrees, and you need minus 70 degrees to tickle the tissue. So, this kind of gradual freeze will at least give you an idea if you're affecting the AV node or not, or the His bundle or not. Now we use it really very rarely. Probably I use it a couple times a year, and that's called focal cryoablation. But in general, radiofrequency ablation is the key, and these kind of heart arrhythmias most of the time are easily to be identified, and success rates up above 95%. Now, the ventricular arrhythmias are much more complicated, and most of the time what we do is to map the area and find out where the scar is and try to isolate the scar by ablating around the scar. But there are really minimal indications for ventricular tachycardia ablations. Why? Because most of the time the ICD is going to be successful unless the ICD is not is shocking the patient too much, or the amiodarone is not successful, or your anti-arrhythmic medications are not successful. In that case, ablation is a reasonable option. So if we go back, it's really very kind of complicated topic, but you should understand that ablations can be done with freezing, or can be done with radiofrequency, which is heat. The radiofrequency part is more powerful, but the damage to the tissue is permanent. So if you have anything close to the AV node, you have to choose the focal ablation, focal cryoablation, because in that case, the damage to the His bundle, the natural conduction system we have, is much, much less. Now, keep in your mind that sometimes if you have a little bit of non-sustained non-sustained atrial tachycardia, or some PACs here and there, or some what we call junk sometimes, that should not indicate an ablation. Medical management should be successful in that case and should be the way to go. But if you have sustained heart arrhythmia, where you can identify either focal atrial tachycardia or some kind of accessory pathway mediated tachycardia, or some kind of reentrant mechanism in the heart where you have a persistent arrhythmia, in that case, ablation is reasonable. So not every time you see a little bit of tachycardia here and there, atrial tachycardia, non-sustained atrial tachycardia, and some kind of multiple different frequency or different morphology arrhythmias, and when it comes to the P waves, you can send this patient to heart arrhythmia. Most of the time, medical management should be the way to go. And remember that multifocal atrial tachycardia, which is everybody knows this disease is related to lung issues. These diseases cannot be ablated, and the treatment of choice is to treat the underlying lung disease, and cardism or verapamil for the time being is a reasonable, or are reasonable options. But most of the time, the arrhythmia is going to be related to the underlying lung disease. Do you have any question about that? So, Should I talk a little bit about sodium and the setting of hypo?
Sure.
So Nick brought up a topic, which is sodium in the setting of heart failure. Remember that low sodium is very indicative of poor prognosis, long-term prognosis in heart failure management, either HFpEF or HFrEF. And remember that it's not really indicative of how much sodium you have in your body, and is indicative of the concentration of sodium in your blood, which is the balance between how much water versus salt or sodium in your blood. And in general, when this balance becomes an issue, it's becoming very difficult to control the heart failure, because almost all your diuretics gonna affect the salt concentration in your blood. And most of the time I tend to treat this with minimizing the water intake and continuation of diuresis. Don't ever treat this with normal saline, because the treatment is not really normal saline to your patient, especially if you're treating somebody at the hospital. The treatment of choice is to continuation of diuresis. If you think that your patient is volume depleted, you can give actually fluids. But if you think that your patient is actually volume overloaded, in that case, you just keep diuresis and minimize water intake. And granted, sometimes, no matter how you deal with it, you cannot really fix it, and you need to give some time for the balance to happen. But I really warn everyone against using normal saline to correct hyponatremia in the setting of CHF exacerbation. That's really not the way to do it. And really no medical management to treat that. Again, it's a balance between salt and water, and in that case, you probably need to just keep giving your patient diuresis, Lasix, and so forth, but minimize the water intake.
Dr. Ibrahim,
Yeah.
can you hear me? Okay. So what do you suggest, like 1.5 liters a day or further fluid restriction?
No, actually it should be less than 1 liter. If your patient,
1 liter?
Okay. For instance, if the sodium below 130, in that case, less than 1 liter of fluids, and extremely minimizing the water. Even your patient might be thirsty, they can utilize a little bit of ice chips at times, but be very careful. A lot of people, they kind of, especially nephrologists, actually, they kind of, try to minimize the diuresis and jump into normal saline. This is really not the way to treat heart failure. It's indicative of the difficulty for the kidneys, brain, and heart to be able to keep good concentration, and that's indicative of advanced heart disease. So you keep diuresing your patient, minimize water, and just keep evaluating your patient. Any other questions, guys?
Do you ever see any use for using the sodium tablets? For some reason, down where I am, they put everyone on salt tablets, and I stop it 90% of the time. But all of the physicians seem to think that that's going to fix it.
Yeah, because they don't really understand the pathophysiology of the disease.
Yeah, I know. So I don't. I mean,
It's
I'm
really,
trying not
it's
to step on toes, but I just stop it.
Think about it this way: if you take, I don't know how to say that in a good way, but if you take your patient and try to dry them and find out how much salt they will have, they probably have more salt than you and mine, than in yourself.
Correct.
And myself. The issue is in the concentration. The issue in the balance between salt and water. not really the lack of
Amount of
sodium.
salt. Yeah.
And
Okay.
family practice physicians and hospitalists, and they really don't understand the pathophysiology of the advanced diseases like that. And sometimes, you know, I have a patient here, her kids are physicians, and they kind of panic about it. But, you know, I mean, sometimes you may need to live with a sodium-funded 2900 theory. You know, I mean, BUN is 60, creatinine 1.2. Patient seems to be a little bit, you know, hypervolemic. Sodium is low. You might not just cut down on the water intake and keep diuresing your patient and evaluate on daily basis on a couple days, and you know, um, and just assess clinically. I'm not sure if, honestly, I'm not sure if treating the numbers are is the way to go in these cases. Just sometimes you may need to rely on the clinical presentation of your patient and the way they feel. You know, sometimes the blood pressure is like 80, they feel great, right? In some advanced heart failure clinics, they don't even measure blood pressure. So just to give you an idea, that numbers always not really the way to go, especially in extremely advanced diseases like that. You know, you're giving salt, so the salt is gonna actually attract water, and all of that's going to the blood vessels in 84-year-old grandma, where it doesn't take that long for her CHF to be exacerbated and balanced. So I really advance against that.
Thank you. Just making sure I'm doing the right thing, stopping all these salt pills.
Yeah, it's wrong. It's a mistake. It's not
I
accurate.
know.
Is there ever a situation from our standpoint where we would give salt pills?
Yes, yes. POTS syndrome, you know, vasovagal syncope, neurocardiogenic syncope, idiopathic hypotension, patients like that, absolutely. But usually in general, they tend to be younger ladies. But if you really cannot treat heart failure patient with salt. That's really not the way to deal with it. And I mean, bodies can really manage hyponatremia very well, unless it's acute or severe. But in general, we can handle hyponatremia very well. Cannot handle hypokalemia very well. We cannot handle hypomagnesemia very well. But hyponatremia, it can be handled very well, actually. So, and again, a sodium is different. Sodium is a balance between water and salt in the blood, the sodium concentration. Potassium, you know, as you know, for instance, in DKA cases, you have, for instance, normal potassium, but you have to make sure that actually the potassium is pushed out from the cells to the extravascular system to balance the acidosis. So you really, if you go back to the medicine, you have to make sure that actually your patient is even hyperkalemic, because you know, once you correct the acidosis, this potassium is going to go back to the cells and so forth. So potassium is different. Maybe magnesium is different, but when it comes to sodium, is really concentration, because most of your sodium is extracellular. I don't know. I've seen some good luck with these SGLT2 inhibitors, Farxiga, Jardiance. These medications, they tend to help heart failure, increase diuresis, get rid of the salt and the sugar in the urine, and seems to be very effective. You know, in elderly people, sometimes you may need to start at 5 milligrams instead of 10. If you need to alternate every other day, you may need to alternate every other day. But I mean, certainly there is some diuresis component to this medication. And actually, they studied this recently, and they found about 1.5 liter difference in 3 days in terms of diuresis compared to only, loop diuretics by themselves. So there's a huge value for these medications for your heart failure patients as well. Any other questions, guys? All right. Good to see you guys.